Good morning, everyone. My name is Gulliaume Lafond. I'm a surgical critical care fellow at Westchester Medical Center in Valhalla, New York, and I'll be presenting the first case this morning. I'd like to thank everybody involved in this case, as well as Dr. Shnaydman, for the invitation to present today. We have no disclosures. These are the objectives for today's presentation, and we'll get right into it. So our case starts with a 19-year-old woman involved in a motor vehicle collision. This was a high-speed head-on collision. The patient was unrestrained and airbags were deployed. Following the collision, the patient was essentially pinned between the dashboard of the car and the driver's seat. Upon response of by fire department and EMS, the patient was actually it took about half an hour to get the patient extricated from the car. And following extrication, it was pretty obvious that the patient had some lower limb deformity, suggesting open fractures. This is a picture at the scene that was provided by EMS. We can see on the lower edge of the picture the hydraulic spreader to really push the dashboard off the patient and allow extraction. This is the other car involved in the accident. You can see this significant damage to the car, suggesting a very high-speed impact. Now, on scene, the patient was found to be hypotensive with a systolic blood pressure in the 70s and a heart rate in the 140s. GCS was 8. At that time, EMS crew just kind of scooped up the patient and brought the patient to our ED without intubation or a volume given. Knowing that we were expecting this patient and MTP was activated, as the patient was brought into the trauma bay, the patient was found to be dyspneic. Despite that, had bilateral breath sounds. Patient was still profoundly hypotensive with a systolic in the 80s. Heart rate was about 120, 130. GCS had mildly improved from an 8 to a 10. At this point in time, lines were placed, so a left subclavian coordinates was placed, right femoral A line was placed, and MTP was initiated. Patient did respond to products. At that point, it was felt to be safe to secure the patient's airway and complete their initial assessment resuscitation. Patient was found to have a stable pelvis, but had obvious bilateral open femur fractures. In terms of our FAST, it was positive basically in all abdominal views, right upper, lower quadrant, and the pelvis. On the pericardial views, there was no evidence of fluid tamponade. Chest X-ray did show a left pneumothorax, what appeared to be a widened mediastinum. A left chest tube was placed, and there was a return of about 400 cc's of blood following placement of the tube. A pelvic X-ray that was done was also normal. In the ED, the patient was given a total of 8 PRBCs, 6 FFPs, and 1. This is our chest X-ray following placement of the left sided chest tube. As you can see, certainly mediastinum looks widened. Beyond that point, there's no evidence of obvious large residual hemopneumothorax at this point in time. So I guess their first question is, what do we do at this point in time? Just to recap, the patient was an MVC, unstable, positive FAST in the abdominal windows, nothing in the pericardium.
Okay. Dr. Supa, your comments, please.
So if this lady is still in shock and she has free fluid in her abdomen, I think she needs laparotomy to check her belly and try to stop the bleeding first. The other things like widened mediastinum or a fracture of the lower extremities or possible vascular injuries can be managed later after we control the bleeding in the abdomen. and try to stabilize the vital signs. Thank you.
Thank you, Dr. Supa. Dr. Fraga Campinas.
Very critical case because the patient is on shock. The patient needs a surgical treatment. So you have some problems because of the widened mediastinum. But if the patient is unstable after the blood, you don't have time to go to the CT. Maybe go first to the OR, open the abdomen, and just a damage control procedure to control the bleeding. And after this, investigate the mediastinum, the aortic injury. And after this, you can fix the fractures on the limbs. It's a difficult case because all segments you have signs of bleeding, and it depends of the experience of the team, what is quicker to have in the hospital to control the first cavity. But I'm a little I have some doubts about the fast exam. And looking off the X-ray, maybe I'm not sure if you can come back to the chest X-ray, if there are pneumothorax on the right. Is there a pneumothorax on the right? I'm not sure. No. On the right, a small pneumothorax or no?
Certainly at this point, I have nothing obvious.
Okay, so if you have the image, a suspicion of the right pneumothorax, for a chest tube, because there is a chest tube on the left. And what was the output on the left with the chest tube?
So initially, upon insertion, there was a 400 cc's of fresh blood that came out, but nothing more in terms of volume.
Okay, so if you have a post-CFS, the patient is unstable, no pelvic fracture, I think it's better go to the OR for damage control surgery. Thank you.
Thank you, Dr. Fraga. Dr. Ochman, Boston.
Well, this patient may have many potential lethal injuries, but we need to go to the one that is going to kill him first. So you have a patient who's hemodynamically unstable. The most likely cause of this patient being unstable is bleeding in the abdomen. Can it be bleeding in the legs? Yes, could be, but the legs you should see. So this patient needs to go to the operating room. The widening mediastinum is worrisome, but you should be able to control the blood pressure when you are in the OR, and immediately after the patient needs to go for pan-CT. He might have a bad head injury. So this is the part that is complicated because normally in a patient like this, I would try to maintain a controlled hypotension, trying to keep the systolic blood pressure around 90. But if he has another head injury, he has a head injury with a concomitant aortic injury, this becomes problematic because what you need to do for one, it will affect the other. So I don't know, I would play by ear, see if they have any evidence, clinical other evidence of head injury, but I would probably keep the patient close to normotensive in this case because I would be worried about the head injury. And as soon as I am done with the OR, I will go immediately to the scanner without stopping in the ICU and scan the head and the chest to rule out the head injury and an aortic injury. Thank you. The limbs take very low priority. That was at the bottom of my list at this time. Thank you.
Thank you, Dr. Ochman. Dr. Colette, Sao Paulo.
Yes. First, I think these patients you can, for start, you have to control external hemorrhage. If these patients have two limbs fractures, I don't know if it's blending, if it's still blending, only compressed dressing or tourniquet may be put in these patients to control external blooding. Of course, you have a very important surrounds of hemorrhage in the abdomen. So these patients need to go to a laparotomy and control the hemorrhage quickly. So I think the problem, you don't see the X-ray, you can see the nasogastric tube maybe from left side. In this situation, maybe I may be thinking about hematoma on the posterior mediastinum can put the nasogastric tube to the right, more right than they be. So I think these patients probably have a aorta injury using this with these steps. So in this moment, I think it's go to a laparotomy, control the hemorrhage, and try to make to see what's happening in the chest. I think it's very important to see if there is bleeding from the aorta or hematoma on the aorta, because the incision, if I go to do it's open, is not very easy to approach on the sternotomy or bilateral thoracotomy, anterior bilateral thoracotomy. You can go to posterior to approach the aorta. You need to go to a posterior lateral thoracotomy, left thoracotomy. So I believe it's very important in this moment when you control the hemorrhage, if the patient continues stable, to take an image of the aorta or the size of the vessels on the chest to choose the correct incision to do the approach if you go to do it open. So that's the way I go. Thank you.
Thank you, Dr. Colette. Dr. Kasim, Portland.
This patient has really multiple injuries, so I will do it in a stepwise patient. She has a head injury, possible aortic injury, definite abdominal injury, and possible vascular injury to both limbs. Now, you can lose as much as 3 liters of fluid from fractures of both femur, so be aware of that, and that needs to be stabilized. And like Dr. Hoffman said, although it is the low priority to do anything there, but it needs to be stabilized. Once you stabilize it, then the bleeding most likely will stop. So what is going to kill this patient? Most likely abdominal injury where he's bleeding. So we need to stop the bleed. So he goes to the operating room, and in the operating room, what I would do would be, I would do pelvic packing, preperitoneal, and then enter the abdomen and fix whatever needs to be fixed inside the abdomen. And then once I've done that, I would, well, before I do that, I also would call my interventional radiologist to see if everything can be set up to send the patient for an aortogram, because this patient most likely has an aortic tear, and it can be fixed endovascularly. Like I've said in previous meetings, patients with aortic tear, when they die at the scene of the accident. By the time they come to the hospital, more than 80% will survive 24 hours. So you still have a little bit of time left to fix the suspected or incipient vascular injury in the thoracic aorta endovascularly. I would refrain from doing a thoracotomy to this patient before I get a CT and consultation with the interventional radiologist. As far as the head injury is concerned, Dr. Hoffman is right. You need to keep the pressure moderate. Although in aortic injury, they recommend you keep the pressure between 90 and 100 systolic, and that is detrimental to the cerebrovascular perfusion. I think you should still try to keep it between 90 and 100, and then hope for the best as far as the head injury is concerned. That's the way that I would manage this. Thank you.
Thank you, Dr. Kasim. Dr. Antrak, do you have any comment?
Yeah, so I think I missed some of the information. After the patient came in, the blood pressure was a bit better, 80 systolic and pulse 125, and then she got the 8 units of packed cells and platelets. What was her clinical status after that large transfusion? Was she a non-responder or what happened?
So she was a transient responder. So there was a temporary improvement in her blood pressure and heart rate, but this was only for a few minutes, and then went back down to her initial vital signs.
Right. So, so in this case, then she needs to go directly to the operating room. You have an ephemeral A line in place, and under other conditions, depending upon how long it takes you to get to the OR, you would have an option to put in the Reboa in zone 1, but in this case, it's contraindicated because of the widened mediastinum. So you can't do that, and the best option goes straight to the operating room to do a laparotomy if you think she may be bleeding from the legs, and also put tourniquets on to temporize for the extremity injuries. But really, there's nothing that you can do you can't really do anything for the presumed aortic tear until the intra-abdominal bleeding is corrected. So I agree with everyone else. Go straight to the operating room, and transient responder with a possible thoracic aortic tear, you absolutely cannot use the Reboa in this case.
Thank you, Dr. Antrak. Dr. Neto, would you like to make any comments, or next?
Yeah, so I agree with everyone. The point that Dr. Antrak just mentioned is very important. We cannot put a Reboa in this patient. This is one of those cases that would really benefit from a hybrid room. I can never find a patient that I'll say, oh, if I had a hybrid room, this would make a difference. But in a case like this, a hybrid room would make a difference, because we would be able to do our arteriogram on the table and all the interventions necessary for the aorta. But here there's no choice. This patient cannot go to CT unstable, and the patient is bleeding in the abdomen. We gotta shut the tap. Thank you.
Thank you, Doctor. Dr. Lafond, we go back to you.
Yes, thank you. So that's, I think these are consensus that really next step will be to the OR to explore the abdomen. And that's what we did. Again, given the fact that the patient was hypotensive and had a positive FAST in the abdominal windows. So we made our way to the OR for an exploratory laparotomy. At that point, we encountered, upon entering the abdomen, we encountered a large hemoperitoneum, about 4 liters of blood was evacuated. The abdomen was packed, and following packing, we found a actively bleeding spleen, so we performed a splenectomy. Otherwise, in the rest of the abdomen, there's a small little laceration that really was not contributing all that much to the hemoperitoneum. Is controlled with cautery, and we had a good look everywhere else. The retroperitoneum also was normal. There was no evidence of zone 3 retroperitoneal hematoma either. It was stable as mentioned previously. While doing this, the patient was still hypotensive, and our anesthesia colleague noticed some new tachyarrhythmias. So some PVCs, but later on some VTach. At this point in time, I'll ask you what would be the next step.
Thank you, Doctor. In the interest of time, and considering that the team has 2 cases, we'll do 2 to 3 comments per stop. Dr. Kasim, would you like to make any comment?
Valeria, may I make a suggestion to the team? Do you want to present the second case next time? Because this is a very interesting case. So you have 2 great cases, it sounds like.
I said the same thing, Doctor. Yeah. We need to find another time, I think, Dr. Shnaydman, for the second case, maybe.
Yeah, let's
I
see
would
how
vote
long
for
this one
that
takes
too.
then. Absolutely.
Okay, perfect. Dr. Kasim, comments?
Well, you're still having hypotension and tachyarrhythmia. That is make my heart go into fibrillation as well. And you're telling us that you didn't find any evidence of retroperitoneal, possible retroperitoneal bleed in the pelvic area. That begs the question, where else is he bleeding from? And you have looked at the abdomen carefully, and you have did what you have to do with the liver and the spleen, and you've stopped all the mesenteric bleeding and all that. So, like I said, that you could lose as much as 3 liters of fluid to 3 liters of blood from bilateral femoral shaft fractures. And but you're giving him somewhat adequate amount of blood, 8 units of blood, and the component therapy along with it. So the question now is, what is happening to the right chest? And I would have put in the right chest tube initially as well, along with the left chest tube. And I would like to know if there is continuing blood loss coming from the left chest tube. And be aware that sometimes these chest tubes get clogged up, and then you may not be accurately seeing the possible continuing bleed of the possible injury to the great vessels in the left chest area. So the question is now, do you open the chest, or do you rely on endovascular colleague to fix the problem? Like my surgical colleague said, that if you are in a hybrid room, this becomes somewhat easier, yet not that easy as well. You have to do a lot of maneuvering to get the aortogram done, and possibly of deploying a stent if there is an injury to the aortic vessel. I am very suspicious there is injury to the aortic vessel and he is hanging by the thread. I don't think he is exsanguinating from that yet, otherwise the patient would have been dead. Remembering that the extrication took quite a long time, etc. So I think I will still rely on my endovascular colleague to help me out in this case, rather than doing a anterolateral thoracotomy at this moment. Thank you.
Thank you, Dr. Kasim. Dr. Antrak, Mirak?
Yeah, so then I assume that there's no output from the chest tube, and as Dr. Kasim suggested, no missed injury on the right side. You'd have to look for that. And then the other possibility with an unrestrained driver under the dashboard is a cardiac contusion and hypotension from lowered cardiac output. So what the quickest way to figure this out, it'd be good if the anesthesiologist had a transesophageal ultrasound probe in place and can give that information. But also, I'd be interested, what's the status of the inferior vena cava in the abdomen? Is it full or empty? If it's full, then that would more argue for reduced cardiac output. But you still have to consider cardiac contusion with low cardiac output, given the PVCs and her still being hypotensive. And you'd have to sort of differentiate between the two then. If it's not a cardiac problem, and I agree with Dr. Kasim, it's the aorta probably is not ruptured. And if there's no increase in the output from the chest tube, that's not the issue at present. And you need to more directly address the cause of the hypotension at this point, whether it's cardiac or hypovolemic.
Thank you, Dr. Antrak. Dr. Pereira, do you have any comment?
Well, I would like to address some questions in the chat. Dr. Wellington from Campinas asked for the chest drain depth. I was wondering if it could give us this information. And of course, Dr. Ultrat said everything. I was especially suspecting of a cardiac injury. Of course, the patient must be assessed totally because he has 2 long bone fractures. He has spleen injury. Probably he sustains a aortic arch or some kind of vessel in the thorax injury, but also he could sustain a cardiac injury, a blunt cardiac injury that could be just a contusion without any bleeding. And this demands some kind of treatment too, and perhaps these arrhythmias could be linked to this. And I've seen once a cardiac tamponade by the aortic injury. So you have a great vessel injury, and this leaks inside to the pericardium, so it tamponates, not having a cardiac bleeding injury. Okay, so I do this repeated fasting. If you find blood in pericardium, you'd have to open the chest. Thank you.
Thank you, Dr. Pereira. Dr. Stubing, you have any comment?
Yeah, thank you. You just talked about my one question about whether we've looked at the heart again with a fast before we move outside of the operating theater, just to rule out, tamponade. I would probably do that before exploring either further imaging, or ideally you'd be in a hybrid room, but those are hard to come by even in developed countries. We don't have any of this in Malawi, obviously, so.
Thank you, Doctor. Dr. Colette, your comments?
In this situation, I have the patients, maybe, of course, maybe a cardiac injury. So in this situation, the patient is open. So I make a pericardial window at this moment and see if there's blood in the pericardium, because sometimes there is no tamponate, but there is a hemopericardium. It can become tamponate soon. So I think it's important to make a pericardial window in this situation and see if there is no blood in the pericardium. The great problem is this hypotension is become from the vessels or aorta vessels or aorta branch vessels in the chest. So it's very important to know who is the vessel, because the incision to treat this vessel is different for the one of the other. If you have injuries on the brachiocephalic branch, you can go to a sternotomy. If you can go to a left carotid, you can go to a sternotomy. But if you go to a left subclavian artery or aorta, sometimes you have to approach, you can be a left posterior thoracotomy. And sometimes you can control the hemorrhage using stents. So sometimes it's possible in the operating room, sometimes call vascular surgery and make an aortography in the surgery. And sometimes you can put the stent in the OR during the aortography. So I think this is very important. If the patient continues unstable with hypotension, you can go to a bilateral thoracotomy and try to fix the injuries. But it's very difficult to use this situation if it is in the aorta, descending aorta near the left subclavian artery.
Thank you, Dr. Colette. Dr. Ochman, Boston?
Well, first, more things are more common. More common things are more common. So the first thing I would make sure that this patient is having these tachyarrhythmias, doesn't have any electrolyte abnormalities, or is hypothermic after the multiple transfusions. Assuming that those are not there, I also am very lucky because I have anesthesia, too many anesthesiologists who can perform a TEE, a transesophageal echocardiogram, which will be my next step. Why this is important, this patient has a widened mediastinum. The TEE is very good to look at injuries. It's very good, obviously, to look for a pericardial effusion that might not have been present initially. It's very good to see the ascending aorta and the descending aorta. It doesn't have a good view of the arch of the aorta. The most common injury for the serration injury in patients like this is a transection of the aorta distal to the left subclavian. Having said that, I have seen quite a few over the years that the area affected is the ascending aorta. A difference between a transection and a dissection is that the dissection that normally happens when we describe the type A and B, it happens in the media, and the dissection runs in the media separating two layers of the media. The aortic tear that is traumatic, usually the media is transected and the whole volume of the aorta is contained by the adventitia, which is very, very thin tissue. Having said that, you can occasionally get a dissection, and it's very important to know if the dissection is proximal or distant to the left subclavian, because the approach is completely different. The ideal is distal to the left subclavian. The ideal approach is to do this endovascularly. If it's proximal to the left subclavian, you have to do an open through a median sternotomy with cardiac surgery. This is a patient that you are, essentially, I would argue this patient is in extremis. You control the bleeding in the abdomen, and he has signs there that he's very close to have a serious arrhythmia and dying, or exsanguinate in the chest, or something bad happening to him. So I don't think this patient can go to the scanner, so I will rule that out. So I would try to get the TE. If the TE is questionable, as Dr. Untrak say, I would, and Dr. Colea would do a pericardial window. And if needed, I would go to the hybrid room. The repair of an aortic tear distal to the left subclavian under ideal circumstances need to be done on the cardiopulmonary bypass. If so, endovascular is the way to go. This patient, we do not know if he has a head injury, so putting this patient on bypass, most likely than not, the head injury will be made worse. So T, and if you have any question, there's a distal to the left subclavia, I would probably move the patient to the hybrid room and continue there with endovascular, doing an endovascular repair. We're knowing very well that this might really, all delays might cause worsening of his potential head injury. I'm sorry, this was too winded. I apologize. Thank you.
Thank you, Dr. Ahmed. Dr. Fraga, your comments?
Can you hear me?
Yes, doctor, we can hear.
Yes, okay. First, can I ask you to come back to the chest X-ray? Because I have some students here. I think this is a beautiful X-ray. Exactly. So I agree with all comments, but it depends the research you have available in your hospital, what you have, what you can do very quick. In our hospital, we don't have hybrid room. I think no hybrid room in Brazil at this moment. And I suggest the team we discussed here to call the cardiovascular team to come. They have a lot of experience to access. I agree with Dr. Parreira. The first step is rule out is if it's not pericardial effusion, you can perform a ultrasound. The first one was normal in the pericardium. I do another ultrasound. You can do this in less than 1 minute, just to make sure that pericardial tamponade. If not, you need to investigate the aorta. It's very suggestive of aortic injury, this X-ray. A lot of signs of aortic injury. So you cannot go to the radiology with this patient. The patient is unstable. So you need to do this at the operative room. So we can do an angiogram in the operative room just to identify if there is an aortic injury. If yes, you need to discuss the best access. Everyone knows that the endovascular treatment is the best approach on stable patients, sometimes on unstable patients. If you have the prostheses available in the hospital, in the ward. Sometimes the patient's very young, the aorta is very thin. You don't have the correct prosthesis to put in the aorta. So I think it's better this approach. If not, you don't have condition to do this. If you have aortic injury, you can try to. It's very difficult to approach the aorta with a sternotomy. I think it's not a good incision to access the aorta because it's posterior, and the same by bilateral thoracotomy. because the access to the aorta is difficult. Maybe you need to put the patient in the right size to open a posterior incision in the chest, posterior thoracotomy to try to access. But it's very difficult. The mortality in unstable patients is very, very high. But I think that you need to try to save the life of this patient. And I consider that the other injuries in the extremity, the bleeding is controlled at this point with damage control, something to control the bleeding in the extremity. It's not the priority at this moment. Thank you.
Thank you, Dr. Fraga. Dr. Supa, your comment. Thank you for your patience.
At this moment, I think we have to find the cause of shock in this patient. We have to rule out the bleeding in other cavities, like everyone else said. Check the chest tube output on the left. Maybe we insert a new one on the right and check what comes out of the chest tube. Quick ultrasonography can check for cardiac tamponade or pericardal fluid. And before closing the abdomen temporarily, I would try to check for other possible source of bleeding, like a retroperitoneal hematoma in the pelvis. And I would try to close the abdomen with a plastic bag to prevent further heat loss. And I would look at the lower extremities for external bleeding that may need control. And if I cannot identify the obvious cause of shock in this patient, for example, if there's no bleeding from both chest, no cardiac tamponade, I would try to rewarm her in the operating room, give her more blood components to try to raise her vital signs. But if I find something that can be correct surgically, like bleeding in the chest, I would dive in the chest. And usually the patient with aortic injury, if the patient becomes unstable from a rupture of the aortic injury, the chance of survival is very low. So in this patient, I doubt that she's actively bleeding from the aorta. Usually it usually lasts longer than several hours before it becomes ruptured. So if possible, after stabilizing her vital sign, I think the best approach to treat the aortic injury in this patient, if she has one, is to do it endovascularly to avoid more big incision for this patient. And we can do that without hybrid room. You can use just a C-arm fluoroscopy and endovascular surgeon. And that's my thought for this patient. Thank you.
Thank you, Dr. Supa. Anyone else, if you have any additional comment, please raise your hand and we'll go back to you in the next step. Dr. Lafond?
Yes, thank you for your comments. So at that point in time, we were not in a hybrid room and the TE probe was not available immediately. So we essentially went for a pericardial window through the diaphragm. Now, to our great surprise, obviously, that there's no obvious blood around the heart in the pericardium. And ultimately, the pericardium appeared normal. Not too long after, the patient basically lost pulses and had to kind of initiate cardiopulmonary resuscitation. So this forced our hand into a left-sided thoracotomy. As we enter the chest, there's some residual blood, but really no new significant hemothorax on the left side. We opened the pericardium as you usually do, confirming that again that there's no significant amount of blood in that space. But the heart did appear empty. We then cross-clamped the aorta and initiated bimanual cardiac massage. Not too long after clamping the aorta, we noticed that the right side of the diaphragm started to bulge. And at that point in time, the right side chest was placed in the right chest cavity, and a massive gush of blood was observed. So at this point in time, I'm asking what would be the next step in this situation?
Thank you. Dr. Resendeneto, do you have any comments?
Yeah, so Dr. Untracked had mentioned that the NG tube was extremely pushed to the right, which was a very good catch there. And when we're discussing this case, I kind of thought that could this patient have such a huge hematoma that would be compressing his IVC, the superior vena cava? Maybe that's what just burst in our face here. So I don't know where it comes from, but this is an interesting thing. It could be a problem with the preload, and that's why the heart is empty despite all that, and just blood is not getting into the heart. So in this case, it's a bilateral thoracotomy, and we need to look at the right chest. The patient is dying, and leave that clamp in the aorta there so you can perfuse the brain, the heart, and the lungs a little bit and look for the source of bleeding. That's my comment.
Thank you, Doctor. Dr. Colette?
Yes, at this moment, I go to a bilateral thoracotomy and see what's blending on the right chest and try to control. I agree with put the aorta clamping and to go to try to make a blood from the brain and the heart at this moment. That's the way I can go.
Thank you, Doctor. Dr. Kasim?
Like I said initially, I would have put a chest tube in when the patient first came in, because when you don't know what you're dealing with, I think it is best to have both chest cavity drained to see if there's bleeding from one side or both sides. So anyhow, now that you're faced with massive blood coming from the right side, you have no choice than to do a clamshell of some type of incision to get into the left side. And he may be bleeding just from one of the pulmonary vessels, not necessarily the supravena cava. And remember, that's what Princess Diana died from, infrapulmonary vein on the left side. So I think you have no choice but to do a right thorax. You open up the right chest cavity and to see if you can get control of that while you have the aortic clamp in place, and then MTP going at the same time to fill up the heart, hoping for the best. I think I would be extremely nervous at this moment, sweating profusely. Sorry.
Thank you, Dr. Kasim. Dr. Antrak, Iraq?
Yeah, so a good point by Dr. Kasim about having opting to have a chest tube on the right side initially, and then it also be reasonable if you leave it out and the condition of the patient changes or is not behaving the way you expect, then as we all do, you have to start over and reevaluate, including, the left chest, and the chest tube was working over there, but also the right chest. And in this case, you may not have had an ultrasound machine available in the OR, but you could, query the right chest to see if there's a hemothorax on that side. Although it may not, there may not have been a hemothorax until the patient lost the pulses. It sounds like that's the case. But otherwise, I think at this point, as everyone else said, you need to open both chests and see what's going on the right side. Just one question: you said when you clamp the aorta, the right diaphragm was bulging, so you can see it bulging up into the right chest. Is that what you observed?
No, from the abdomen.
Because initially, from the abdomen, you could see it bow into bulge down into the abdomen,
yes.
into the abdomen. Okay, yeah, because initially the right hemidiaphragm was very high, so there's a lot of pressure on the right side. So that suggests that probably there was no bleeding into the right chest until that happened, and then the patient lost the pulses. So if you'd had a chest tube in place, it wouldn't have mattered. And even if you'd done the ultrasound, you may not have seen anything happen until you know, the patient lost the pulses. So it's kind of immaterial. Those decisions not to do those things are immaterial, and you just need to do what everyone else said, is clamshell and go both chests and see if you know, it'd be heroics at this stage, but that would be what you need to do here.
Thank you, Dr. Onstrak. Dr. Ochman, any comments? We cannot hear you, doctor.
Hello, sorry. Can you hear me now?
Yes, we can hear you now.
Oh, I'm sorry. First, tip of the hat to Dr. Kasim, who was right once again when he recommended the right side of the chest tube, which I admit I wouldn't have placed, but in retrospect, that was the right thing to do. When we have massive bleeding from the right chest, the main thing I would be worried, that would have been that initially it was a diaphragmatic injury and bleeding from the liver, which is more common, but now we know it's not bleeding from the liver, so it's something inside the chest. My first thought when I see the bulging of the diaphragm, it will be a tension pneumothorax rather than a hemothorax, but kind of like this case is really very confusing. I would probably have proceeded straight to a clamshell incision. I found that the left anterolateral thoracotomy is a very limited incision to, I don't think I ever did a pure left anterolateral thoracotomy that I did not extend it through the sternum at least and eventually to the right chest, because it's very limited access, and a wide incision over the right chest gives you an excellent access. So where this patient can be bleeding? Probably the lung, as Dr. Kasim also correctly pointed, because that's the most likely source. If they would have said that the pericardium was not okay, or was a tinge of blood in the pericardium, I would have assumed a right atrium, which is also something that rupture frequently with a hole in the pericardium that allowed the bleeding from the pericardium to escape. And so this case, I think, is close to death, if it's not dead already. I think the only chance is to do an clamshell incision and see if it's anything that can be quickly clamped on the other side. If it's a pulmonary hilar injury, it's a young patient, surprisingly will be very poorly tolerated, a cross clamp of the hilum. But at this time, this patient is dying. You should try anything that you can try. That's all I have. Thank you.
Thank you, Doctor. Dr. Supa, your comments, please.
I agree with a clamshell thoracotomy at this moment and try to stop the bleeding from the right chest. Thank you.
Thank you, Dr. Supa. Dr. Fraga Campinas.
I agree. This patient is dying, and I think the clamshell thoracotomy is the best option to identify the injury, maybe the superior cava vein injury. I think it's not injury from the atrium because the pericardium was without blood, but clamshell as soon as possible. Thank you.
Thank you, Doctor. Dr. Pereira, do you have any comment?
Open the chest. Let's see what happens.
Okay, thank you, Doctor. Dr. Lafond, we go back to you.
Okay, so I think consensus is here to kind of extend from the left to the right via clamshell incision, and that's what we did. So upon entering the right chest, we kind of basically evacuated the hematoma in the chest, mobilized the lung, and actually found an SVC tear with active hemorrhage. So initially direct pressure was applied, obviously, and we tried to repair this primarily. Now, this is kind of our initial laparotomy incision and the clamshell incision here. And then I can show you the right chest. So we can see the lung that's been reflected anteriorly and medially, exposing the SVC and the posterior wall, the chest on the right side. You see a better view here. We have the diaphragm, the left lower quadrant, and then again, lung reflected, and as you see, has been repaired there, again, with what we had at the time. Now, despite this, after having controlled the laceration and the SVC, at that point, the manual cardiac massage was ongoing, and despite multiple pushes of epinephrine, bicarb, cardiac, and calcium, really, we were not able to get spontaneous circulation back. Patient had a total of 18 units of PRBCs, 16 PRBCs, 18 FFPs, platelets, and crystalloids, amongst other products. And actually, it's after half an hour, then it was thought that any further effort would be futile, and the patient was pronounced dead, essentially.
Thank you, doctor. Should we go to the final comments?
I have a question to ask. Is
Sure,
this
Dr.
the tear in the superior vena cava? Is it at the junction of the azygos as it drains into the SVC?
It's a good question. I don't recall exactly the actual location. It was, again, extrapericardial, but the actual location with the azygos, I don't recall exactly. Maybe Dr. Shnaydman can add any comment to that?
Yeah, I agree. It was hard to tell, but I think it was superior to that.
Thank you. Should we go to final comments? Maybe Dr. Kasim, would you like to make final comments?
Well, this is one hell of a case. There's a lot of good pearls from the presenter. He gave us lots of clue, and I think it is something that we should take it seriously and remember this case for a long time to come, because I think we will encounter this again in an injury like that was shown, and heroically managed, quite methodically. I'm sorry you lost the patient, but I think you gave it all. It's a good case to remember. Thank you.
Thank you, Dr. Kasim. Dr. Pereira, do you have any comment?
Phenomenal case. Thank you so much for sharing. I think you have really will help us in the next ones. I would like to say again, I'm sorry you lost patient, as Dr. Kasim remembered. I'd like to ask you, have you had any kind of invasive catheter through the internal jugular or the subclavian during the operation? I've seen such an injury in patients with Charlie catheters passed through the internal jugular veins. I'm not sure it can be a possibility here. Thank you.
Thank you. So there was a catheter, there's a cordis in the left subclavian that was put in the ED with the initial resuscitation.
Perhaps the wire sometimes can puncture and make a tear, something like that. I'm not sure this is a possibility here. I think it's not. I think it's due to the trauma, but sometimes. Thank you.
Thank you, Dr. Pereira. Dr. Supa, final comments?
Very interesting case, and I think you did your best to save this patient. And I'm looking forward to seeing your second case very soon. Thank you so much.
Thank you, Dr. Supa. Dr. Fraga, Campinas.
Unfortunately, the patient died, but I think it's very difficult for this kind of injury survive in other place, like you have a good trauma system in the United States. Maybe the time between the trauma, the event, and the definitive treatment was about 2 hours. In countries like here, Latin America, Sometimes this patient go to the wrong hospital. You don't have our shooter to treat a patient like this one, and the patient will never survive. In other case, more simple than this one, sometimes they die too. So congratulations to present this case. We learned a lot. Today, our room have so many students here. They are come back after this crazy pandemic. They are come back to the medical school. And I think our students and residents that are here learn a lot you never forget. The X-ray for me is very suggestive of aortic injury, but the same for the superior cava vein injuries, like the same aspect of the X-ray. And sometimes it's what you're having in some hospitals to have a suspicion of this very difficult injury. Congratulations for the team who did the best for the patients.
Thank you, Dr. Fraga. Dr. Ochman, your final comments?
Well, for me, this was a very humbling experience because I never saw a blunt, I have seen penetrating injuries of the IVC and SVC, but I haven't seen a blunt injury like this one. So this is the chest tube that Dr. Kasim recommended placing. Really, I learned a lot today. I think if I would have put the chest tube first and I have seen the blood and it has deposited fast, I would still probably have gone to the abdomen, except that I would maybe recognize earlier that something else was going on in the chest, because in those cases, the most common source of bleeding is a diaphragmatic injury and bleeding from the liver. But you quickly rule that out, so we probably open the chest a little bit faster if I would have done as Dr. Kasim recommended. Dr. Pereira made a very good point about the possible injury with the cordis. I have seen an injury to the right ventricle through a cordis, through a right IJ. They are rare because the wire is soft at the end, but they can happen, certainly can happen. Having said that, this appears to be a long laceration. So I think this was a result of big acceleration injury, very unusual injury, very, I would say, very well managed considering everything. Yes, this patient died, but if she had a chance, you gave her every possible chance. So the great case. I'm glad that we only presented one, because I imagine the second one is probably as interesting as this one. So if we get two great presentations, congratulations to the team. Very, very good case. I'm sorry the patient died, but I don't see him die for anything that you did wrong. Quite the opposite. Thank you.
Thank you, Dr. Ochman. Dr. Colette?
Yes, congratulations for the case. It's a very interesting case. I think sometimes you need image exam to treat patients to know the surrounds of the blood. Sometimes I don't have time to do this, but sometimes it's very important to try to put the patient unstable or transitively stable and make an image to treat this. And one thing is very important is because this patient is unrestrained and airbag explosion. This mechanism of the trauma usually make injuries of the chest, any chest vessels and organs. So it's very important that when you use airbag, you must be rested by Daost. I have a case that's one of the first time I see the airbag injuries. It was a patient was big. Open the airbag and there is a cardiac contusion, and open the pericardial tear through the abdomen, and the right is in the abdomen in this case. So it's very important that the patients, where you see unrest patients, airbag explosion, you can thinking about the chest injuries quickly. Thank you.
Thank you, Doctor. Dr. Shnaydman, do you have a couple of slides, or Dr. Lafond that you would like to share?
We have a few more slides. I just wanted to add a comment. Thank you all for joining. We share this with an unfortunate outcome, but a very interesting case. I think a lot of us learned from this case, and hopefully, we take what we learned today for the next patient. In this case, what was bizarre is if you remember back to the original chest X-ray, the right hemithorax was fairly clear. The costophrenic angle was visible. There was certainly not a massive hemothorax. When we did clamshell after the right diaphragm was bulging into the abdomen, I mean, this was like a 3 to 4 centimeter laceration in the SVC. So this was not a subtle thing that would have been missed initially. So this was, I think, a delayed rupture. And temporary, it seemed to be related to the cross clamping of the aorta, although it is bizarre that a left-sided cross clamping will cause right-sided pressures to go up and then cause a right-sided rupture. But that was kind of the bizarreness that we were dealing with. Unfortunately, despite getting full control of hemorrhage in the abdomen and chest, the patient did not survive. I think part of the problem was even the splenic laceration was not very, very severe, but I think the prolonged extrication and the blood loss at the scene, the patient came in extremis so metabolically deranged that I think all chances were lost. But thank you everyone again. And Dr. Untrack, for the autopsy, I don't believe the autopsy really revealed much more than we already know. I don't recall getting an autopsy report with any surprising findings on her.
Did it show the aortic tear?
I have to look
You don't
back.
know yet.
I haven't received it yet.
Thank you, Dr. Steuben. You have any comments?
I have one question. Do you think during the extrication, since it's taking so long and knowing the patient has bilateral femoral fracture and possible other bleeding source, we should recommend some type of intravenous fluid resuscitation or blood resuscitation in cases like this?
Yeah, we routinely, our EMS, depending on if it's BLS or ALS that gets to the patient, they do have fluids and medications available. This patient, I believe, it was kind of a scoop and run situation. They weren't too far from the hospital. Our helicopters here in our hospital, unfortunately, don't have blood products, but occasionally we'll get helicopters from neighboring states, which do give blood products en route. But our EMS and our helicopters here in our area do not give blood products. They only have fluids and medications. And if it is an ALS, they will intubate as well.
Thank you. Dr. Steuben, would you like to make any final comments?
Thank you. Yeah, this was a really interesting case. And I mean, like our resident was saying, oh, it's not a happy ending, but I think there's so many lessons to be learned, and from everybody who's been learning from this case, somebody will be saved in the future from what we heard today. So thank you so much for this. I will just say that in regards to the discussion about the central line placement and potentially being contributing to the SVC injury, we had a similar case in my training where the person inserting the central line turned the wire around because the soft part was not going easily. And so the sharp end went nice and easily, but it went straight through the atrial wall, and then they started infusing the pericardium and the patient died. So I wonder if something like that may have happened, but just as a warning to everyone, don't ever turn the wire around because it's not so safe that way. Thanks.
Thank you, Doctor. Dr. Antrak, final comments?
Yeah, so sad case and very, very interesting. And I think the takeaway lesson here is, as Dr. Kassim mentioned, a case where you have head, chest, abdominal, and extremity injuries, and the patient is transient responder. I think it's probably prudent, even if you think you don't need it, to have chest tubes on both sides, especially if there's already an injury on one side. And perhaps that might have given you an early warning if suddenly it started to put out blood and she was getting hypotensive. Perhaps you might have opened the chest sooner. But in any event, based on this test, that's what I would do differently next time. I don't know what the consensus of your group was, if that would have made a difference, but it's too bad. And had this person had been belted in, likely they wouldn't have succumbed to the injury in this case. That's that's unfortunate.
Thank you, Dr. Armstrong. Dr. Resendeneto, final comments?
So it's an interesting case, and I think the team did what everyone would do here: follow the same steps. And what would be more common in this case would be a aortic injury, but it's a very interesting case. That NG tube in that chest X-ray was telling us something, Dr. Untracked.
Thank you, Doctor. Okay, thank you. Dr. Shnaydman, any final comment?
Yes, Dr. Lafond, you want to just share the last couple of slides? We just have a quick review of the literature, given that this is such a rare finding.
So again, saying that SVC injuries are quite rare, and if they do happen, typically it'll be following a penetrating trauma, not so much a blunt injury. And again, these often are fatal if they do happen. And they tend to be classified between intrapericardial injuries and extrapericardial injuries. If they do happen at the intrapericardial level, they'll often be at the atrial junction. And these will present often with hemodynamic collapse following tamponade. Again, left-sided extrapericardial injuries are more rare than intrapericardial injuries and will present with a hemothorax. In most cases, for the intrapericardial injuries, the injury will be approached via a median sternotomy. I just had a handful of case reports here. These are actually about intrapericardial injuries. I could not find any cases of extrapericardial SVC injury, despite my best efforts. This case is a case from Philadelphia. Basically, same mechanism as our case, basically MVC, Carvus's tree with prolonged extraction. The patient was unstable, intubated, brought to ED, had a transient response to blood products. In her case, had negative FAST at the level of the abdomen, but did have a positive FAST on the pericardial view. And for that reason, the team went straight to the OR for sternotomy and found to have a laceration as the SVC joined the atrium. In this case, what the team wanted to relay is that often these can be accompanied by other injuries. In this case, the patient had an injury to the innominate artery just prior to the bifurcation, and also had a dissection into the left subclavian artery. A few pictures here. On the right-hand side, we can see the injury control with a vascular clamp. And this case was repaired with horizontal mattress sutures with pledgets. The innominate artery injury was also repaired the same way, and the dissection of the left subclavian was managed medically. This is another case, again, of a intrapericardial SVC injury. In this case, presentation was a little different. It was the same mechanism, but at that point, the patient was stable, essentially, presented mainly complaining of chest pain. Given the fact that the patient was stable, the patient, following initial assessment, went on to have a CT scan and showed what appeared to be a contained aortic rupture, as well as the left clavicular fracture. And there's note of a insignificant pericardial effusion. Based on those results, the team was planning for an endovascular repair, but shortly after, the patient became unstable and forced the team to take the patient to the OR, again, for a median sternotomy. Much like the previous case, upon entering the pericardium, basically by releasing the tamponade, the patient's hemodynamics improved instantly, and the SVC laceration at the atrial junction was repaired primarily. The aorta was then dealt with endovascularly as well. And in both cases, the patients did well and were discharged a few weeks following their initial surgery. So this is kind of what the what we can find in terms of SVC injuries, again, there's a handful of case reports out there, and most of them have been intrapericardial. Pictures of the second case here. Pictures of the median sternotomy. The black arrows kind of point towards the laceration, just as the SVC kind of joins the atrium here. And these are references. Yeah, this is kind of a very quick review of what's out there in terms of SVC injuries. Thank you.